CONN syndrome or primary hyperaldosteronism. Usually patient present with new onset, difficult to control hypertension and symptomatic hypokalemia, for example palpitations and paresthesias. This patient typically likely has primary hyperaldosteronism. Primary hyperaldosteronism is a common cause of secondary hypertension, often results in hypokalemia after initiation of the thiazide diuretic, although spontaneous hypokalemia can also occur. The effects reflect the role of aldosterone, which stimulates sodium reabsorption and potassium secretion. The first diagnostic step is to measure plasma renin activity and plasma aldosterone concentration. Elevated plasma aldosterone concentration of more than 15 with plasma aldosterone concentration by plasma renin activity ratio of more than 20 suggests the diagnosis. If these tests are abnormal, primary hyperaldosteronism can be confirmed by determining the urine aldosterone level after an oral sodium load. A sodium load normally suppresses aldosterone secretion, but it does not suppress aldosterone secretion in patients with primary hyperaldosteronism. CT scan of the adrenal gland and adrenal vein sampling can be used to distinguish between unilateral adrenal adenoma and bilateral adrenal hyperplasia. Surgery is usually preferred for unilateral adrenal adenoma. Medical therapy with mineralocorticoid receptor antagonist, example spironolactone, is recommended for patients with bilateral adrenal hyperplasia and those with adrenal adenoma who do not undergo the surgery. So remember the triad for the CONN syndrome. It would be hypertension, which is usually difficult to treat, and there will be symptomatic hypokalemia where you can see paresthesias and palpitations, and the hypernatremia are the usually the triad for the CONN syndrome. Thank you.